Today we are going to present a presentation as a part of the national campaign for the proper use of antimicrobial liquid for 2019. In this presentation, we'll just give a brief about the situation of the multi-drug resistant organism as an infection related to the improper use of antimicrobials, and what are the core elements for the antimicrobial stewardship program, and what is the situation in Kuwait in a survey conducted earlier during October. So as you all know, because of the widespread availability, familiarity, generally low cost and relative safety, antimicrobials are among the most misused of all medicine. And when we say antimicrobial, we don't mean only antibiotics. But you know that we have antiviral, antifungal. So are the most among the most misused of all this medicine. And 50% of antibiotics are misused either because they are used in treating and managing viruses, or because I'm using the broad spectrum instead of targeted antibiotics. So what are the consequences of this abuse of these antibiotics? As you all know, the allergic reaction, the drug interaction, and side effects, especially if these antimicrobials are taken without prescription, so the drug interaction could happen. A Clostridium difficile infection that we started to observe nowadays in our hospitals, and emergence of a resistant strain. In the United States, the Clostridium difficile are estimated to be about 250,000 and among the healthcare-associated infection every year. Most of these infections are due to or related to the abuse of the antibiotics. At least 14,000 die each year in the United States from the Clostridium difficile infection, and most of this infection could be prevented. So what is the situation of the Clostridium difficile infection here in Kuwait? Over the last 3 years, the percentage of the Clostridium difficile infection in relation to the other gastrointestinal infection, healthcare-associated infection reported in Kuwait, you can see that it has increased from 56% up to 75% in relation to the healthcare-associated infection, gastrointestinal infection. And per Clostridium difficile infection alone, when we see the rate, then we can see that the rate per 10,000 patient days has been increased from 0.5% up to 1.05%. So in terms of comparison of the Clostridium difficile in relation to the gastrointestinal infection, it increases, and Clostridium difficile infection per se also increases. As the antimicrobial resistance, the European Union estimates that about 700,000 die each year due to the antimicrobial resistance. And although this is a low estimate, however, it is higher than the deaths due to measles, cholera, and tetanus. And they expect that in 2050 it will reach 10 million. Again, what is the situation here in Kuwait? Over the last 3 years, the multi-drug resistant organism isolated from the healthcare-associated infection, I'm not talking about colonization, I'm talking about infection. You can see that for the major group, ESBL, CRE, multi-drug Acinetobacter, multi-drug Pseudomonas, the VRE and MRC, for all groups it increases. But what is astonishing that, for example, for the Acinetobacter, about 80% of the Acinetobacter are multi-drug resistant organisms. For the Pseudomonas, over the last 3 years, it increased by 10% to reach about 40%. So the problem and the burden of the antimicrobial resistance are increasing. So what are the actions? The WHO has launched in 2015 5 elements to fight against this antimicrobial resistance. The first of all is to improve the awareness, understanding of the antimicrobial resistance with the effective communication, education, and training. to have a good surveillance system to actively detect this multi-drug resistant organism and proceed immediately. Reduce the rate of infection through the proper effective infection prevention measures, sanitation and hygiene. To optimize the use of the antimicrobial in human and animals. So it's not only in human, but also in animals. But our concern will be mainly on the human. And the fifth element, develop the economic case for sustainable investment in the research, vaccines, diagnostic, and other intervention. So our talk will be on the antimicrobial stewardship. So what do we mean by the antimicrobial stewardship? It's optimizing the antimicrobial selection, dose, route, duration of therapy to maximize the clinical cure and prevention of the infection. Subsequently, it will limit the unintended consequences such as the adverse drug event, the cause and emergence of resistance. So I have in this antimicrobial stewardship program to target the inpatient and outpatient department to avoid the excessive duration of therapy and restrict the use of more potent antimicrobial to the serious infection. So in simple terms, the antimicrobial means right drug, right dose, right duration, and recognized when not needed. The CDC has published the core elements of hospital antimicrobial stewardship program with 7 elements: leadership, commitment, the accountability, drug expertise, action, tracking, reporting, and finally education. So the leadership commitment, any program that has to be run should be committed by the leadership in the hospital. The hospital director, the head of department, they have to be committed to this program to provide the necessary human, financial, and information technology resource. For the antimicrobial stewardship program, it should be conducted or run by a drug expertise, a physician leader who should run this program, and a pharmacy leader who has to co-lead this program. Okay, so we have to have a leader to run the program, a pharmacy who has to help him and co-lead the program, and we have to have from the different departments, from the clinician, from the infection control, from the microbiologist, from the nursing, and one is an important element in the information technology because we need them to run the system. Action. So we have the leadership commitment, we put the team, so how to run the program, what are the actions? So the action, we have to implement the policies and the intervention. And this intervention could be a broad intervention, pharmacy-driven intervention, or infection and syndrome-specific intervention. And what is important when we are going to implement this intervention, I have to put the priority, avoid running too many policies and interventions simultaneously, so to avoid any failure. And it should be based on the need and the feasibility inside our facility. And the policies that support the optimal antibiotic use by documentation of the dose, duration, indication for the all courses of antibiotic, and develop and implement facility treatment recommendation, again, based on our policy. So what are the examples of this intervention? The broad intervention, we have the antibiotic timeout. What do we mean by antibiotic timeout? That for any patient that I started antibiotic, I have to review this antibiotic within 48 hours. After I did the necessary and the required investigation, and I have to review if this antibiotic I need or I have to stop it or shift to another antibiotic. So this is the antibiotic timeout. Prior authorization. And prior authorization, I think this is going on in all hospitals, that some of these antibiotics should be countersigned by a consultant or a senior. Another element or another intervention, the prospective audit and feedback. A prospective audit and feedback means that a pharmacist or a physician has to review this prescribed antibiotic before the patient takes it, to review if this medication could lead to any drug interaction or has any drawbacks for this patient, so we can shift it to another antibiotic to improve the use. The pharmacy-driven...
Sorry for interruption. Do we have to interrupt or...
Sure.
Why prospective? You mean before using?
Yes, before use.
How you do this? And if I'm going to write something for the patients, who's going to just review me after that, for example?
So you
give something for the patients.
تمام.
So who's going to revise it before the use?
عادة الفارماسي لازم يكون في فارماسي ليدر بيشوف الميديكيشن ده مع الاذر ميديكيشن مكتوبه للبيشنت ده، اذا عنده اي انتي بايوجرام واضح ريزلتس او ما عندوش، لكن لو عنده اي ديزيز فالكلينيشن برضه بيشوف وبيتاكد اذا ما فيش اي دراج انتراكشن، اذا الدوز محتاجه يحصل لها اوبتمايزيشن.
يعني الفارماسيست
او الفيزيشن الاثنين مع بعض. فارماسي والكلينيشن مع بعض. عشان كده احنا لما جينا اتكلمنا ان احنا في التيم بيشتغل على البريسكريبشن والدراجز وهاو تو اوبتمايز هاو تو بروبر يوز، ملوش دعوه بالكلينيشن ديسيجن قد ما هو بيديله بعد كده فيدباك ان for this patient we had to shift, we had to change the dose or the antibiotics according to the situation.
يعني I don't know about this specific point, but usually whenever we have a decision to start some antibiotics for a patient, usually it's not a single decision by only one guy. Usually it is one and another senior with him like this. This should be enough, I think, from our side as physicians. But from the pharmacists, I think you are asking for what? From the pharmacist to revise.
And pharmacy has to revise if there is
the clinical pharmacist in this situation to stay with the...
Yeah, clinical pharmacy definitely
around with the
result. A clinical pharmacy is needed to review if possible drug interaction will happen for this patient. So
I don't think we have this.
Dr. Asamu, do we have a clinical pharmacist right now in the hospital?
I think we did some few times.
At a small scale.
Small scale.
I think we remember before. So it's okay.
So this is the broad pharmacy-driven intervention. For this patient, he presented with some symptoms. So you started antibiotic, broad spectrum antibiotic. Okay, you did investigation, and you found that this patient, for example, has, found pneumonia, and he has. You did culture, and you found that this patient does not have bacteria, but has, for example, syncytial viruses or influenza. So at this point of time, the antibiotic may not play a role here. This patient might start, for example, if he has flu, might start the Tamiflu, which is antiviral. Within 48 hours, I completed my basic investigation and screening. So accordingly, I can shift to the better.
This will not affect the resistance antibiotic after that later on. As Dr. Sir told before, if we start an antibiotic for 5, plan for 10 days and became as viral, after 48 hours of stop the drug, quick resistance will come.
تمام. يبقى احنا بنبدا ببوليسي، يكون عندنا policies عشان according to the disease that we observe. اوكي لازم بنقول احنا ايه زي ما بنقول البروفيلاكسيس وايه التريتمنت. تمام. هل لو انا باخد as a prophylaxis for 48 hours I stop, I will develop a resistance? I don't think so. Because and that's why for the surgical site infection prophylaxis, we see that the antibiotic should to be only for 24 hours. Only for open heart.
3 doses.
3 doses.
Yes.
3 doses.
So it doesn't develop resistance. 48 hours, no.
So for the surgical site infection, only with the open heart surgeries and joint replacement surgery, the duration of antibiotics it can be extended.
When it will develop resistance after how many days it will start antibiotics?
Doctor, not always develops resistance, doctor. There is no guideline which tells us that after 48 hours, after 72 hours, it's going to develop. Depends upon the organism, whether the bacteria is there.
The abuse. So if this patient does not need the antibiotic and I'm insisting to continue the antibiotic, so this will lead to the resistance by the antibiotics.
Also depends upon the duration in getting the culture result. Suppose patient has infection and culture will get culture after 3 or 4 days. We can't keep the patient plagued without antibiotics.
Culture now more advanced techniques in the lab, okay, that can give you the results within hours. For negative result دلوقتي الدكتور for negative result أنا خلاص مش محتاج الأنتيبيوتيك، لكن أنا within 48 hours I can modify the antibiotic if I need or if I don't need. يعني أنا بيبان within 24 hours إذا أنا بتكلم في جرام بوزيتيف أو جرام نيجاتيف أكتر، within 48 hours بيبان الأنتي بايوجرام ريزيستنس ستريم شكلها عامل إزاي، فهقدر بعد كده أختار الأنتيبيوتيك. فهي دي الفكرة. النيجاتيف كلتشر هي بتاخد فترة أطول عشان أنا بتأكد إن السامبل ما فيهاش ناف قوي إن هي تتاكل ما فيه. The second group of action, the pharmacy-driven intervention, like for example, the automatic change. احنا معلش بس كنا بدأنا So the pharmacy-driven intervention, and that's why we said that we need the information technology and the IT not only to generate the antibiogram and communicate and give feedback, but also some alerts. For example, if there is unnecessary application of antibiotics, so when you enter the new medication for this patient, it will come like an error, so you cannot give it to the patient. The automatic change from the intravenous to the oral antibiotic. The pharmacy-driven intervention like the dose adjustment and dose optimization. The time-sensitive automatic stop-up. So for this patient, he should have the antibiotic for 5 days, 7 days, or 14 days. So by the end of this course, it will stop and it will give you an alert. So this all the pharmacy-driven intervention. The infection and syndromic intervention, like in the policy, it should be written treating of the community-acquired pneumonia, urinary tract infection, skin and soft tissue infection, surgical prophylaxis, MRSA, Clostridium difficile infection, and treatment of culture-proven invasive infection. And I think in all our policies, these are covered.
Pharmacy-driven again alerts. How we are going to contact it?
The pharmacy.
Again, the pharmacy will call us or something like this?
Clinical pharmacy. The method of communication دكتور علاء هي دي اللي محتاجين فيها الاي تي سيستم يكون في عندنا اوتوميتد، كل حاجه اوتوميتد تبلغنا. الكلينيكال فارماسي هيشارك في الراوند لو في اقتراحات او في دراج انتر اكشن. بيرسونال كوميونيكيشن مهمه، لكن احنا we cannot rely on personal communication. ان انا يعني في مستشفى زي كده عندي كام ديبارتمنت، في الديبارتمنت في كام وحده، الراوندز محتاج كام كلينيكال فارماسي تشارك في الامر ده. فالكلينيكال فارماسي هيبقى موجود ويشارك في الراوندز، بس انا لما يكون عندي اوتوميتد سيستم يدينا الالرت او النوتيفيكيشن ده او الفيدباك هيسهل الامور.
Do we have it? Oh, that's my question. Do we have it? I don't think so.
لسه ما احنا بنتكلم احنا دلوقتي احنا we have antibiotic policy. Each of the departments here has an updated antibiotic policy. طيب نطبق بقى البوليسي، هو ده اللي احنا جايين نتكلم فيه النهارده، ان احنا ازاي نطبق البوليسي ده والديفكتس عندنا احنا فين.
I think it's better to continue lecture and discussion later.
Yeah,
the lecture is not.
Yes.
And continue lecture.
Okay. We continue with the elements, the core elements, tracking. So monitoring the antibiotic prescribing and the resistance pattern. So we have the audit of the antibiotic use process, so periodic assessment of the use of the antibiotic and the treatment of infection to determine the quality of the antibiotic use. The antibiotic use measure the consumption by defined daily dose or day of therapy. So for the defined daily dose, is by the number of grams for each antibiotic should not exceed this number. So we can calculate it in the hospital if we exceed or not. And a day of therapy, so we calculate in the infection control the patient days. So a day of therapy on the antibiotic for the all patient. These are the measures to evaluate the consumption of the antibiotic and the outcome measures. For example, we can have the rate of hospital onset of Clostridium difficile and the number of infection developed resistant super infection. Finally, by the reporting and the education reporting, so we have to give the feedback for all involved in the program, the consultant and the physician, treating physician, even the nurses and the relevant staff. Education by giving a newsletter, presentation, the feedback, regular update on the antibiotic prescribing and the antimicrobial resistance. So these are the core elements. So what is the situation here in Kuwait? So we conducted a survey that we covered all hospitals, governmental hospitals in Kuwait in October, 20 hospital and tertiary care centers. And we can see that only in 60% of this center we have a formal leadership support to have, I'm not talking here about an antimicrobial stewardship program, but at least antibiotic committee. So only in 60% of the facility there is a formal leadership support for the antibiotic committee. 20% there is a physician leader for this antibiotic committee. The pharmacist in 40%, and the key support group that we discussed, you can see that the infection control and the microbiologists are present in 55%, so in almost this 60% where there is an antibiotic committee, we have the infection control and we have the microbiologists. But for example, the information technology are present only in 20%. What are the actions to support the optimal antibiotic use? The policies, there is facility treatment policy in about 95% of these facilities. But when we go for the intervention, you can see here there is variation. For the infection and syndromic, you can see that it covers a lot of healthcare-associated infection with the exception of Clostridium difficile because it was not the scope of some hospitals, this Clostridium difficile, like for example, in most of the tertiary care, like Sabah al-Ahmed, IDH, infectious disease hospital, they don't see this Clostridium difficile, so they didn't put in their policy. That's why you can see that it's missed. But what about the broad intervention? Do we have antibiotic timeout? It's only yes in 40%. The pre-authorization 90% because most of the antibiotics should be reviewed and signed by a senior. So this is present. The prospective audit, it's only in 65%. For the pharmacy-driven intervention, IV to oral, it's only present in the policy in 30%. Dose adjustment 75%. The automatic duplicate alert and automatic stop order 35%. Again, the problem of this automated system who solve this problem. Tracking by monitoring the antibiotic prescribing use and the resistance. The process measures, monitoring the adherence to documentation, only 15%. So we do not audit. We have the policy, but do we follow the policy? Do we follow what is written, or we just modify according to opinions? So monitoring adherence to the treatment guidelines and the documentation policy is 15%. And monitoring the compliance to the intervention 5%. The outcome measures, the healthcare associated infection, we do evaluate in all governmental hospitals, so that's why it's 80%. The antibiogram report in 80% in the facilities. But when we go for the antibiotic consumption, we don't know. we don't have any tools or audit how much antibiotic has been prescribed, how much antibiotic has been used. Only in 2 facilities they do it by the direct expedition. So they have in the pharmacy how much they requested for the antibiotic and how much does it cost. But the prescription and the use, we don't have.
Excuse me, but why it's kind of because it's easy.
They are not doing it. Simply, they are not doing it. Okay. The reporting information to the staff, the antimicrobial distribution is 70%, and personalized communication is 75%. Education only in 70% about the proper use of the antibiotic. When we did more, this data was merged all the facility, but when we go for the departmental, we have more information according to the department. Policy available in about 82% of the department, yes, and it's updated in about 82% of the department. Is the policy inclusive for the dose, duration, frequency, and route of administration for all elements? It's only on 76%. But the frequency for each indication is 100%. For the department, we have grouped all the departments all over with the medical, surgical, pediatric, obstetrics, ICU, and you can see that the policy is available in all departments. Okay, there is no department that they don't have a policy, but it could be affected. The percentage depends from one hospital to another. So when we merged the department, it affected. But is it updated in the last 2 years? Only the rehabilitation center did not update their policy, but most of the other departments, especially the pediatric ICU and the oncology and the pediatric, they updated in the last 2 years. Is policy inclusive of all disease encountered? Most of the department, with the exception of the emergency, said yes. And let's say that they did, most of the department, as we presented before, they did not put the Clostridium difficile. There could be a complication of the antibiotic use. Is policy inclusive of the all elements? We mean the dose, duration, timing, the frequency and route of administration. The rehabilitation and oncology are the only 2 departments that they have put all this, and we can understand the oncology why they are doing that, because they are very precise in their medication. But for the other departments, the surgical in 80%, but the other departments, you can see the variation between 60 and 70 for all the elements to be present. Is policy disseminated to all physicians in that department? The PICU and ICU rehabilitation and the pediatric are above 90%. The other departments are about, again, between 70 and 80s. We can understand because the PICU and ICU and they are more closed departments, small departments, so it's easy to disseminate. But for the other departments, especially for the emergency, it's only 50% that they have the policy disseminated to all them. So finally, the antimicrobial stewardship is partially implemented in the Ministry of Health Hospital, so we recommend more formal leadership support, greater accountability, and improved drug expertise in the form of physician and pharmacist leaders, focus on increased broad and pharmacy-driven intervention to support the optimal antibiotic use, increase reporting to information staff. Antibiotic policy are mostly available in different clinical departments, so we recommend to distribute the policy to all physicians of each department, ensure the policy included the duration of therapy for each indication. Finally, antimicrobial resistance is a worldwide serious public health problem, including COVID. It's a complex problem that affects the society and is driven by many interconnected factors, and coordinated action is required to minimize the emergence and spread of antimicrobial resistance. Thank you. And any questions? We have here, we have the opportunity, Dr. Al-Najah, Mudir Mustashfa, Dr. Osam from the pharmacy, microbiologist, and you as the leadership in the department. So it's the best time to discuss how can we implement this program right now. This is important. We have policies. We have updated policies here. But what is the problem? We have to assess our problem here first.
ممكن ابدا؟
تفضل دكتور.
بسم الله الرحمن الرحيم والصلاه والسلام على رسول الله. بالنسبه للانتي بايوتيك يذكرني تحدي هنا نفس التحدي اللي جيت انا منه في المستشفى الولادي. فالإجابة من الآخر أي شيء يصطدم بمصالح الشركات المنتجة للأنتيبيوتيك راح يبوء في الفشل ما لم يتخذ قرارات جادة مشتركة وعليها مراقبة ومتابعة واستمرارية، مو لشخص يقود باسمه إنما بسياسة تنفذ من الوزارة وتكون في صدق ناس مخلصة تنفذ السياسة. الانتيبايوتكس والحملة ضد الانتيبايوتكس ما لازم ترتبط بيوم واحد بالسنة عالمي، لازم يكون في بوليسيز، والنقص في البوليسي اللي أشرت فيه هذا دليل على أن فعلا البوليتكس هي اللي موقفة تنفيذ أي شيء ضد الانتيبايوتكس. أنا ماني ضد الشركات، ولكن الشركات مثل ما تنتج شيء مفيد للإنسان عليها أن تضع مصلحة المريض في تسويق الأنتيبيوتيك، والدكتور have to be هو أمير العيادة، عارف شلون متى يستخدم الاستخدام الأمثل للأنتيبيوتيك، هو اللي لازم يسأل عن الأنتيبيوتيك السايد إفكت، الكونترانديكيشن، انتراكشن، whatever متعلق ليش؟ لأن احنا عايشين الحين بدينا نجني ثمرة الأدوية اللي دخلناها بقوة إلى البرايمري كير. قبل يعني أول كانت الأنتيبيوتكس محصورة في المستشفيات العامة، الحين صار في البرايمري كير تقدر تاخذ whatever يعني كل الجنريشنز اوف انتيبيوتيك يو كان يعني ستارت with it. فهذا معناته ان احنا مقبلين على جيل من الريزيستنس اجينست الانتيبيوتيك، فلازم نكون عندنا سياسه محطوطه يعني كبيره واحنا جزء منها كمستشفى، بحيث انها تكون جاده في ايقاف هذا يعني يكون في اخلاص، والدكتور المسؤول الاول والاخير. صحيح الاداره تراقب، ولكن دور الدكتور في العيادة هو وضميره أنه يبدأ لا يعتقد أن هذا الدواء هو أول دواء نوصف، لا يعتقد أن هذا الأنتيبيوتيك هو أول أنتيبيوتيك نوصف. فهذا اللي يخلينا ندخل في المالتي ريزيستنت، واللي هي الحين صارت منتشرة عندنا في مستشفيات السبسبشن.
احنا دكتور نجاح، احنا الحملة بتاعت الأنتيبيوتيك هي ممتدة كانت على مدار شهر، بادية من يوم 21 أكتوبر حتى 21 نوفمبر. والحملة الانفكشن كنترول، إدارة المنع العدوى، أخذت الليد في الموضوع ده بناء على القرار الوزاري بتاع معالي وزير الصحة بإنشاء اللجنة الوطنية لترشيد استخدام المضادات الحيوية برئاسة الدكتور عبد الرحمن المطيري، والمقرر بتاعها الدكتور أحمد طبع رئيس إدارة المنع العدوى. وبدأنا نشتغل. فكانت أول حاجة عملناها احنا فين من الانتي مايكروبيال ستيوردشيب بروجرام على مستوى الدوله، فين احنا لقينا فاريشن. انا مش عايز اقول مين هي المستشفيات اللي عندها انتي مايكروبيال ستيوردشيب بروجرام رانينج كويس. انا عارفهم من حكم الشغل اللي انا اشتغلته في السيرفي، لكن it's easy to do it لو احنا يعني نعمل البروجرام، تو ران البروجرام، هنقدر نشوف فين المشاكل اللي بتواجهنا ونقدر نتخطاها. زي ما في حاجات الدكتور علاء وحضراتكم اشرتوا اليها. طيب احنا دي هنوقفها ازاي؟ الالرت ده هنعرفه ازاي؟ النوتيفيكيشن بتاع الابلكيشن ده ممكن ناخد بالنا منه ازاي؟ ممكن يكون الجينيريك نيم مختلف، لكن هو في الاخر نفس السبيكترم اللي انا بشتغل عليه. كل الكلام ده انا وفعلا عندي كلينيكال فارماسيست، وعندي ناس ديديكيتد للبروجرام ده من الكلينيشن، وعندي اوتوماتيك سيستم اقدر نبتدي نشتغل فيه، هيبتدي يعمل لنا يعني لو الدكتور ما غيرش من نفسه زي ما حضرتك تفضلتي او قلتي الدكتوره نجاح، على الاقل مش هيبقى في ايده ان هو يصرفه. يعني الدكتور كتبه خلاص، راح للصيدليه، الصيدليه ما يقدرش يصرفه لان عنده الف.
يقدر يقول له روح اشتغل من الصيدليه الخارجيه دكتور. احنا عارفين.
لكن
يعني
انا مع حضرتك،
انا كنت اقول لك الاوتوميتد ما راح يكون رقيب جيد مثل الدكتور، هو نفسه يطور.
متفقين ان ضمير الدكتور هو ده الحل، متفقين. لكن احنا بنعرض الداتا، عشان كده في الاول خالص قبل ما حضرتك تيجي على طول كنت عرضنا الداتا بتاع الريزيستنس. يعني احنا اما نرجع للداتا بتاعت الريزيستنس على مستوى الدوله، ده في اخر 3 سنين احنا 80% من الكالتشرز بتاعت الاسيمتوماكتر مالتي دراج ريزيستنس. احنا في اخر 3 سنين الريزيستنس بتاعت المالتي دراج ريزيستنس اسيمتوماكتر زادت ب 10%. احنا الكيرف بيزيد، الكيرف بيزيد. احنا ما فيش جروب اوف انتي بايوتيك، جروب اوف مايكرو اورجانيزم الريزيستنس بتاعه بيقل، كله بيزيد. فهي دي المشكله. عشان كده احنا بنقول بنعرض الداتا دي لحضراتكم. دي الداتا عندنا، دي مش داتا مثلا جايبينها من السي دي سي في امريكا او وورلد وايد، لا دي الداتا بتاعتنا احنا. دي المالتي دراج ريزيستنت امونت الهيلث كير اسوشيتد انفكشن. يعني لو احنا بنتكلم على الكولونايزيشن الريت ممكن يكون اعلى.
عفوا دكتور ما بخاطر دكتور، انت تو من الفيزيشن اوكي او تو من الفارماسيست او تو من الوزاره او من بالضبط تقصد اللي يعمل ابيوز والشغله هذه؟ من برايك دكتوره؟ الدكاتره الفيزيشن يصرفون او الفارماسيست؟
طبعا هي مالتي بس النسبه تختلف من مكان الى مكان اخر. يو كانت استيميت ما دام ما في ميجرز تو ستارت وذ دائما علشان تبدا برنامج وتعرف ان انت حققت فيه نجاح ولا لا. لازم في البدايه تسوي ريكورد احصائيات
صح
وبعدين تسوي اناليسيس
كوميتي او مثلا بحيث انه يضم المشمولين بالشغله هذه مع الوزاره وبعدين يحط مثلا
لان هو البيشنت
بوليسي او اي حاجه.
patient is coming for you as عباره عن تراكمات، قاعد يروح مستوصف، قاعد يروح مستشفى خاص، قاعد يتصل في رويال صيدليه رويال بدون وصفه وهي الانتي بايوتيك وات ايفر هي وونتس. معناته ان اللايف از ايزي وصار اوفر ذا كاونتر. يعني it becomes easier. يعني الانفايرمنت شجعت. الدكتور بالنسبه له ما راح يصير عفوا يعني ستريكت ما لم يكن هناك عندنا كلينيكال ميتينجز، توعيه زياده من القسم نفسه، مراقبه من مراجعه اداء من قبل رئيس القسم. اذا كان رئيس القسم انترستد الكل راح يكون
بس عفوا دكتور لا تنسي انت حضرتك ذكرت شويه، لا تنسي دور المريض. يعني فرضا انه راح مستوصف ما عجبه او قصدي هذا يروح براي اي صيدليه برا. يعني معناته عفوا
في شيء من
المسؤول الابيوز ولا الشغلات هذه ولا هذا ليس محسوبا بالطبيب او هذا.
بس بالنسبه لنا انا قاعد اتكلم عن نحن.
احنا بنتكلم عن سكوب احنا هنا في المستشفى. لكن هو في زي ما احنا قلنا في الكونكلوجن، وزي ما اللجنه الوطنيه لترشيد استخدام مضادات الحيوي حاطين كل ديبارتمنتس، يعني حاطين كل اداره من العدوى، الخدمات الصيدلانيه، الرعايه الاوليه، المختبرات، علشان الموضوع يعني انا مش عايز احل في حته والاقي ان ما زالت المشكله مستمره في حته. واحنا عارفين ان يعني مشكله كبيره موجوده برضه في البرايمري هيلث كير، ان المريض بيروح and insist for having antibiotics، وهي دي بتبقى مشكله. فانا بحاول يعني وجهه نظر ان احنا هنا حتى في الهوسبيتال when we I don't want to say limit the use, but when we use it properly, at least we will not face a lot of multi-drug resistance generating inside the hospital, and we can easily control it for the future.
I'd like actually to say something. Now we can correct our behavior. I mean, as a healthcare givers, we're supposed to correct our behaviors, but we don't know what is the patient doing. But still, we can control it, by the way. And it is not that bad, by the way, that we have how many departments we have. Each department should have his policy for the treatment of the antibiotic policy. This should be known and written, and it is not for each surgeon or physician just to write whatever he likes. No, it should be guidelines. These patients have been like this, I should give him this. This is in the guidelines, and we should follow these guidelines. We have to get the book or the report, guidelines are there. Patients coming to me with UTI, I will give him only this. This is the first shot. This is the first antibiotic I have to go. And we have to follow this. We have to audit this. Is he running on the guidelines or not? And after that, we have to correct our other facilities for the way. For us, if we have a patient, we have to give some empirical treatment for antibiotics, broad spectrum antibiotics. This should be given in the guidelines. And we will follow it after 48 hours. If we corrected the microbiology to give us as fast as we can from the culture, so I can de-escalate and go to the other second one, which is narrow spectrum, and this will be helpful for us. And to follow this, and by the other alerts you are telling. So it is not a big issue to get from each department its policy, antibiotic policy, for prophylaxis and for treatment for all his patients, and then follow it and audit it, and then help him by alerts like from the physician, from the pharmacist, and like this. This will help us for everything. But it's not, I would disagree with Dr. Nagah that any doctor will come and just write for the sake of the company, of the pharmaceutical company. No, we are running for something. Maybe this is the primary care, Dr. Nagah. In the primary care, primary care, in the polyclinics or so, he will come with some source, what he will give him anything. But in our side, we have to run for the guidelines.
I have been through hospitals. From my experience, most of the things, activities are covered by antibiotic companies. So don't deny that because you are working in that way. Others are working in another way, دكتور. بعدين في شغلة ثانية جديدة. أي شيء جديد في الخدمة والحمد لله يعني أنا مريت عليهم وشفت المختبر إن عندهم جهاز الكلتشر اللي يكشف الكلتشر خلال كم ساعة؟ ساعتين باي ذا واي يعني هذا شيء جديد لربما اللي يعرف
for MRCN
yes
MRCN CRE
yeah it's very limited again
but
this is what they can do
يعني I think بنعمل resistant enterobacteriaceae طب بنعمل resistant acinetobacter طب بنعمل resistant pseudomonas الحاجات دي يعني وين الام ار سي احنا بنتكلم على 4 out of 6 initial groups in the multi-drug resistance.
أنا أقصد دكتور we have a good chance إن إحنا tertiary hospital we have a good equipment يعني now in the way it is working within 2 hours the culture will be ready. So no idea of starting antibiotic which maybe يعني resistant. Wait the 2 hours till the results come and then start the antibiotic. This is a new protocol can be added because every new يعني أي جهاز جديد لازم يعلن عنه you know if they know
my respect is too difficult for everybody every patient
by the way
I mean inpatient not outpatient
before giving any antibiotic it's too difficult to implement such a thing and before giving any antibiotic, okay, I have to send for culture and send it.
I mean inpatient, not outpatient.
Yeah, this number one. Number two, أنا بخصوص البروتوكول policy everything there. المطلوب implementation.
This is based on the.
كل شيء موجود. كل شيء بس ما هي مشكلة.
By the way, this issue of the cultures, the doctora, this issue of the cultures is not right, it's not correct. We cannot do except only for the MRSA for only once. Because I cancelled one transplantation yesterday because I'm waiting for the culture for 5 days. And so if this issue of the culture is coming to be ready in 1 hour or 2 hours, this is not right, this is not correct. If we have this, it will be the best, but we don't have it. If we can get this facility, it will be the best. They can say, but they are maybe shy to say.
It's not a culture, doctor. That result which you're getting of MRSA is a PCR.
Yes, PCR, that's right. It's one hour. But the culture, can we get it in 1 hour?
No, doctor. The organism has to grow. It takes
So
certain
we have to
ways.
wait. We have to wait.
Depending on the
regarding the monitoring, you have 3 stages because this is the aim of our meeting here, so we can commit the leadership to the monitoring process. We have in the laboratory, we have the sensitivity this and this done. So who gonna monitor? The pharmacist, the lab, our microbiologists, physicians, or the pharmacy side? So from where we can start the monitor? Or it will be a combined work?
We can divide the monitor into three groups.
Stages.
The process measures. So this is the monitor will be during the round. So during the round, if I have a clinician who is dedicated for the antimicrobial stewardship program, so he can review. Okay, for this patient, the policy says for this condition, this antibiotic first drug of choice. This is the second line. Are the treating physicians comply with this or not? So this is the process measure. So monitoring the policy and the treatment facility guide.
دكتور انت كرئيس منعدوى كم واحد؟
احنا في الجروب بتاعنا الهيلث كير اسوشيتد انفكشن.
كم قسم يرجعون لك او يعطونك فيدباك مالهم اذا كان بروتوكولات جديده او ما شابه ذلك، وكم قسم يستعين فيك كانترفنشن؟
كانترفنشن لا، انترفنشن ما حدش بيستعين فيا انا كانترفنشن، لان هو بيستعين بالمايكروبيولوجيست، لان هم المايكروبيولوجيست هم اللي هيقولوا لهم الانتي بايوجرام باترن بتاعه ازاي. فهو الانتي كانترفنشن المايكروبيولوجيست، وده بيحصل، يعني ده اكشولي بيحصل، واحنا يعني ده بيحصل. احنا في الجزء الثالث اللي هو الكونسامبشن ميجرز. الكونسامبشن ميجر اللي هو باي ديفاين ديلي دوز او داي اوف ثيرابي او اكسبيرينشال. اكسبيرينشال وده اسهل، ان هو انا مثلا الصيدليه كان ميزانيتها كذا، كان مصرف على انتي بايوتكس. ده ابسط مثال، وده اللي معمول هنا فقط، يعني مش ما كانوش عايزين، لكن معمول في السيرفي بتاعنا في دوله الكويت، هو ده الطريقه المعموله. لكن الديفاين ديلي دوز والديلي اوف ثيرابي مش معمول. الديفاين ديلي دوز هي اصعبهم، لان انا كل انتي بايوتيك لازم احسب هو المفروض ما يتعداش الجرعه بتاعته كام في اليوم، وبحسب انا بتخطى قد ايه، فده اصعب. الدي اوف ثيرابي اسهل، لان الدي اوف ثيرابي هيتحسب انا عندي كام بيشنت موجود عندي، كام واحد فيهم اخذ انتي بايوتيك، وتبقى كيوميتيف. فهو الدي اوف ثيرابي دي اسهل، لكن دول برضو الاثنين دول برضو مش موجودين عندنا كاليمنتس اوف مونيتور. زي ما حضرتك قلت دكتور، احنا عندنا بوليسي موجوده تمام، لكن قد ايه ملتزم بالبوليسي؟
مين بقى who supposed to check this؟
هنا في جروب هنا اعتقد الجروب اللي هنا الفارماسيست، هنا اعتقد الجروب اللي هو لازم يكون من كل ديبارتمنت في واحد ديديكيتد للموضوع.
So I think we need to make a body authority to with one or two or three of what we said now, just to cover and to check with each department, is he following the guidelines for the antibiotic policy or not, and to give a report. These people are not following, these people are following.
ده التشكيل اللي احنا كنا اتكلمنا فيه دكتور.
اعتقد الميكروبيولوجيست لازم ياخذون يعني جزء كبير. انا بس يعني مايكروبيولوجي ليش؟ لان بالنسبه حتى انت الايج اللي يو ار ديلينج البيدياتريك غير الادلت غير المسنين، لان if you go to the geriatric group minimum inhibitory concentration will change from age to age. فالميكروبيولوجي هم اللي هذا الاكشن مالهم يتطلب ان هم اللي يبدون، يعني المبادره تبدا منهم، هم اللي يعطونا يقولوا لنا هذا البروتوكول صح يمشي، اي بس يفندونه على الايج، على السكس، على السيركمستانسز. احيانا انت الحين تقول ما ابي استخدم انتي بايوتيك، في بعض الدكاتره مرينا عليهم كان يقول اشياء غريبه لانديكيشن اوف انتي بايوتيك. احنا في طب العائله كانوا يقولون one indication of using antibiotic for upper respiratory tract infection which is يعني مع الاسف يعني داعي للسخريه examination. يعني one is coming as a student, tomorrow is his examination, one is يعني لما يجي ويقول اعطيني علاج ابي اطيب فاعطيه انتبايوتيك، هذا one indication. لاحظ صح، وب اندر سوبرفيجن الميكروبيولوجي اعتقد المجال جدا. وبعدين لازم تعطيه الاذر تشويس، مثلا فور سمبل انت هني في الترشري يو هاف تو يوز فور برايمري كير فور سمبل مثلا اللي هو ترانزيانت upper respiratory or transient gastroenteritis. Do you have the good choices, alternatives other than antibiotic available يعني انا واحده من الصديقات تقول لي رحت ابي مضاد حيوي من الصيدليه. قال لي نعم صيدليه تبيني اوصف لك في دوله من الدول الاوروبيه تبيني اوصف لك انه مضاد حيوي، احنا ما نعطي مضاد حيوي، لكن اعطاها دواء بالياتيف يعني شغله من الريميديز والاعشاب والاشياء المتعارف عليها عندهم، خلال يومين كانت لها اروع ما يمكن وشي واز ساتيسفايد. هذا معناته ان الساتسفاكشن الفكره تغيرت لان فعلا في بديل جيد بدون استخدام مضاد حيوي.
ده التشكيل الجروب اللي احنا كنا اللي هو السي دي سي ان هو لازم يكون يعني في فارماسي ليدر، في بغطي على كل الديبارتمنتس، مايكروبيولوجيست، انفكشن كنترول، كواليتي، نيرسز حتى لازم يكونوا موجودين، انفورميشن تكنولوجي، يعني حتى الدكتور يعني الاوديت يكون دكتوريشن، او حتى لو عندي تيم ليدر من النيرسز يبقى ديديكيتد للموضوع ده، تبقى بنشوف ايه اللي مكتوب في البوليسي انا في الديبارتمنت بتاعي، مثلا في حمد العيسى الحاله دي مثلا سيرجري، تمام؟ طب انا السيرجيكال بروفلاكسس بتاعها ايه؟ طب البيشنت ده مثلا بعد 10 ايام حصل له انفكشن.
You need to create this team. You need to create this team and
Okay,
create
that's
a
fine.
team
Doctor,
to do this.
who you are suggesting?
No, you have to get you have to get some bodies not from the departments. And I cannot share, for example. The physician cannot share. You have to get one dedicated for this. He will be hired or assigned for this. He's not to be as physician and then after not doing this. No, he should be a team all the time like that. 4 or 5 at first to revise all the guidelines given by the departments as a protocol for their policies for antibiotics, whether prophylactic or treatment, to revise it at first, and then to tell them, okay, agreements. And we did this with the microbiology, by the way. And all our policies, we did it with the microbiologists, and we agreed, we signed for it. After that, after revising this, they have to follow, are you following or not? And check why you are not following, and they have to discuss this. So this will be audited, it will be good.
So by the microbiologist, we will do it with the microbiologist
Of course,
as leader of this. They will lead this.
Whatever the team who's the leader, but we have to get a team.
So the leader.
But separate, not I cannot tell them come and do because they have the job already.
This is that's why we are here for different specialty, and we need to agree on something. Because as physicians know which type, maybe it's not why it's not from pediatric, why it's not from, so the leader of this process will be from the microbiologist.
It will be better to be.
Okay, because the co-leader by